congenital heart diseases can be divided into two types. First is acyanotic congenital heart disease, another type is cyanotic congenital heart disease. In case of acyanotic congenital heart disease, we have left to right shunt. In case of acyanotic congenital heart disease, we have left to right shunt. So there are three examples in which there will be development of left to right shunt. So one is atrial septal defect, then we have ventricular septal defect, then we have patent ductus arteriosus. So these three are diseases in which there will be development of left to right shunt. So now I am telling briefly how it is left to right shunt. So this is our heart. So if there is a defect in intra-arterial septum, so this is left atrium, this is right atrium, left ventricle and right ventricle. So blood will flow like this because the pressure in the left atrium is always greater than right atrium, so blood will move in this direction. So it is atrial septal defect. So there is defect in intra-atrial septum. It's like that. If the defect is in interventricular septum, that will also lead to development of left to right shunt. And in case of patent ductus arteriosus, we know in PDA it connects pulmonary trunk to aorta. So aorta is like this, it is connected with pulmonary trunk. In pulmonary trunk, it is connected with the right ventricle, and the right ventricle is connected with the right atrium, and right atrium is connected with the superior vena cava and inferior vena cava, and this is the right heart. So this is right ventricle, this is right atrium, and this is the pulmonary trunk and their pulmonary arteries. So this is aorta. Aorta is connected with the left ventricle. This is left ventricle and this is left atrium, and this left ventricle is connected with the aorta. So blood goes like this. So this part is called ductus arteriosus. It is present in the fetal life. Ductus arteriosus is present during the fetal life. So after birth it closes. In some person it remains, like in case of congenital rubella syndrome, there is patent ductus arteriosus. If the ductus arteriosus is present, then it is left ventricle, it carries oxygenated blood, and this blood will come to the right ventricle. So there is also left ventricle connected with the aorta, so this is left, and pulmonary trunk is connected to right ventricle, so this is right. So it is also a type of left to right shunt. So these three are the example of left to right shunt. One is atrial septal defect, one we have ventricular septal defect, another is patent ductus arteriosus. So we'll discuss about all three in brief. So first we'll start with atrial septal defect. So in case of atrial septal defect, there is defect in intra-atrial septum. Okay, so this is our intra-atrial septum. This part is called intra-atrial septum. I am making ventricle small to explain this intra-atrial septum in detail. So first there will be development of septum primum. Septum primum, there will be defect in septum primum. It is called septum primum. This foramen is called foramen primum. There is another defect present in septum primum. This defect is called foramen secundum. So foramen primum and foramen secundum both are present in septum primum. So another thing, we have septum secundum. Septum secundum develop like this, and there is also a foramen present in septum secundum. This is called septum secundum. This foramen is called foramen ovale. So suppose we have a defect in closure of this foramen primum, then it will develop ostium primum type of ASD, or it is called primum type of ASD, we can call it in short. That is primum type of ASD or primum ASD. Okay, in case of ostium primum ASD, there is a defect in closure of lower part of the septum. It is the lower part of the septum. So if the defect in closure of lower part of the septum, it is called primum ASD or ostium primum ASD. So lower part of the septum fuses with this part. It is called endocardial cushion. So if the defect in closure of foramen primum, there will be also defect in endocardial cushion. So it is also associated with endocardial cushion defect like valve defect. This endocardial cushion develops into valves. So if there is defect in the lower part of the intra-atrial septum, there will be also defect in endocardial cushion. So it is also associated with valve defect. The primum type of ASD is most commonly associated with valve defect. Which valve defect most commonly? It is mitral valve defect. Okay, so primum type of ASD is associated with mitral valve defect. It can be also associated with tricuspid valve defect also. In case of mitral valve, it is associated with the anterior leaflet. In case of mitral valve, we have two valves, one is anterior and posterior leaflet. In case of tricuspid valve, we have anterior, posterior and septal. So in case of mitral valve, we have anterior leaflet defect if it is associated with primum type of ASD. In case of tricuspid valve, it is associated with septal leaflet defect. So this is all about primum type of ASD. Now we will discuss about other type of ASD. So we discuss about primum type of ASD. Now we will discuss about other type of ASD. Another type of ASD is called secondum type of ASD. That is defect in closure of foramen secondum. So what is secondum type of ASD? It is defect in upper part of the septum. So it is defect in upper part of septum. It will lead to development of ostium secondum atrial septal defect. So if defect is in lower part, it will lead to primum ASD. If lower in the defect is in the upper part of intra-atrial septum, it will lead to development of secondum ASD. Okay, another type of ASD we have, that is called sinus venosus ASD. So this part is called sinus venosus. Okay, sinus venosus means this part is associated in the mature heart. Suppose this is a mature heart. So this is right atrium, this is left atrium, and the right atrium is connected with superior vena cava and inferior vena cava. Okay, so in close to superior vena cava, if we have a defect here, this is called sinus venosus type of atrial septal defect. Sinus venosus type of ASD is SVC type. If we have a defect here, it is connected with inferior vena cava, it is called sinus venosus atrial septal defect associated with inferior vena cava. So another is there is defect is coronary sinus ASD. So there is defect in, it is near the coronary sinus, defect in intra-atrial septum near coronary sinus. It is called coronary sinus ASD. So we have now four type of atrial septal defect. Atrial septal defect is we classified into four types. First is primum ASD, then we have secondum ASD, we have coronary sinus ASD, another type we have sinus venosus ASD. So we have primarily these four type of atrial septal defect, out of which secondum type of ASD it is the most common. So in case of secondum type of ASD, there is defect in upper part of the septum. In case of primum type of ASD, there is defect in lower part of the septum. And primum type of ASD is also associated with endocardial cushion defect or valve defect, most commonly mitral valve's anterior leaflet. If it is associated with tricuspid valve, then there will be septal leaflet of tricuspid valve will be defective. And we have coronary sinus ASD. It is very rare, and it is between atrium and the coronary sinus. In case of sinus venosus type of ASD, at the junction of superior vena cava and right atrium, there will be an opening. This opening will connect both right and left atrium. This is called sinus venosus type of ASD. It is seen near SVC type, and it is also seen as IVC type. So these are the type of atrial septal defect. Now we'll discuss what is the difference between atrial septal defect and patent foramen ovale. Are this is the same? No, this is not the same. So what is the difference between atrial septal defect and patent foramen ovale? So this is foramen ovale. So after, suppose in a person there is no atrial septal defect, so this is closed, this is closed, so this is closed in this person. Now in a mature person there will also closure of foramen ovale. So how foramen ovale will close? So foramen ovale will close if it will close when there will be fusion of septum primum and septum secundum. So when these two will fuse, that will lead to closure of the foramen ovale, and it will form fossa ovalis. Closure of the foramen ovale leads to formation of fossa ovalis. So suppose this is our septum primum and this is septum secundum. I am doing it in different color. This is septum primum, suppose this is septum secundum. In septum secundum we have a defect, this is called foramen ovale. In case of septum primum we have two defects. In the one is in the lower part and in the upper part. So this is called foramen secundum, this is called foramen primum, this is red one is called septum primum, and this green one is called septum secundum. When these two will fuse, what will happen? When these two will fuse, there will be like this structure will be like this. So this is called foramen ovale. Now it is when these two will fuse, this will be obviously closed. So if this foramen ovale is not closed, if these two structures are not fused with each other, then that will lead to development of patent foramen ovale. Okay, so it is different from atrial septal defect. Septal defect is most commonly associated with foramen primum or foramen secundum, or we can call it ostium primum or ostium secundum. But patent foramen ovale is a totally different thing. It is due to defect in fusion of septum primum and septum secundum, and once it is fused in normal heart, this is called fossa ovalis. So this is how it is different from the atrial septal defect, that patent foramen ovale. This is how it is different. Now I will discuss more about the atrial septal defect. So what happens in atrial septal defect? So this is our heart. So if there is a defect in here between left atrium and right atrium, obviously the blood from the left atrium will flow to right atrium. So what will this lead to? This will lead to volume overload in right atrium. So it will lead to cessation of volume overload in the right atrium. So once there is volume overload in the right atrium, where this blood will go? This blood will go to right ventricle, and from the right ventricle, if there is volume overload in right ventricle, this blood will go to pulmonary trunk. From the pulmonary trunk, this blood will go to lungs. So if this happens chronically, it happens for a very long period of time, what will this lead to? This will lead to pulmonary arteriolar vasoconstriction and pulmonary vascular remodeling. So this will lead to pulmonary arterial vasoconstriction and hypertrophy of the smooth muscles. Those are present in the tunica media of the blood vessels of the lungs. They will undergo hypertrophy, and that will lead to pulmonary arterial vasoconstriction, and this is called pulmonary vascular remodeling. So what will this lead to? This will lead to pulmonary hypertension. So once there is pulmonary hypertension, it will develop in a very long time. So suppose one patient is with ASD, he will develop pulmonary hypertension in many years later. Suppose one has VSD, ventricular septal defect, and this defect is larger than the ASD, and now there is volume overload in the right ventricle. So volume overload in the right ventricle, that will lead to volume overload in the pulmonary trunk. Then those blood will extra blood, it will go to lungs, and the same process, pulmonary vascular remodeling and development of pulmonary hypertension. So after a long time it will develop pulmonary hypertension, but the time taken in case of ASD to develop pulmonary hypertension is more than VSD. In case of VSD, he will develop pulmonary hypertension faster. So what happens if he develops pulmonary hypertension? So suppose he develops pulmonary hypertension, so there will be increase in resistance of pulmonary blood vessels. So right ventricle will have to try more to pump blood into the pulmonary trunk or lungs. So this will lead to right ventricular hypertrophy, because right ventricle is pumping more, using more pressure to pump the extra blood into the lungs, in which the arteries are already undergoing vasoconstriction. So it will require more pressure, it will work more. So this will lead to right ventricular hypertrophy. So if the right ventricle undergoes hypertrophy, there will be increased pressure inside the right ventricle. So if there is increased pressure inside the right ventricle, this will also lead to increased pressure inside the right atrium also. So if the pressure inside right atrium increases, it will lead to reversal of sound. So now the pressure of right atrium is more than right ventricle, left atrium, sorry. So if the pressure is more than right atrium, of the right atrium is more than left atrium, so there will be reversal of sound. First the sound was left to right, now the sound will be right to left. So this whole phenomenon, this is called Eisenmenger syndrome. So this is called Eisenmenger syndrome. So Eisenmenger syndrome, it is a late complication of uncorrected left to right sound, like we see in case of ASD, VSD or PDA, that progresses to pulmonary hypertension or pulmonary vascular remodeling, which leads to reversal of the sound. Now this sound will be reversed from right to left. So this is called Eisenmenger syndrome. So it is seen most commonly in case of VSD, then PDA, then ASD. So Eisenmenger syndrome seen in case of VSD more than PDA, more than ASD. So this is all about Eisenmenger syndrome. So what happens more in case of ASD? So in case of ASD, there will be flow from like this. So there will be no sound murmurs heard in case of ASD, but in case of VSD there is a murmur, very loud murmur. It is called pan-systolic murmur. So it is heard throughout the systole in case of VSD, but in case of ASD there is no such murmur. So in case of ASD, what happens is that when there will be, I told you, volume overload in the right atrium, then there will be volume overload in the right ventricle. Normally what happens during inspiration, there is an S2 split. So this is our S1, suppose after S1 is due to closure of mitral and tricuspid valve, S2 is due to closure of aortic and pulmonary valve. So after S1, once the mitral and tricuspid valves are closed, then there will be ventricular systole. So after the ventricular systole, there will be closure of aortic and pulmonary valve. So A2 closes before the P2. So this is A2, this is P2, both make S2. So during inspiration in normal person, there is physiological splitting of second heart sound during inspiration, but during expiration there is no splitting of first heart sound. So high during inspiration there is a splitting, physiological splitting of H2. So inspiration, it creates a negative intrathoracic pressure, so that will lead to increased venous return to right heart and decreased venous return to the left heart. So inspiration, it creates a negative intrathoracic pressure. Inspiration creates a negative intrathoracic pressure that will lead to increased venous return to right heart, right atrium, right ventricle, that is right heart, and decrease venous return to left heart or left atrium, most commonly, not left ventricle, most commonly right atrium and left atrium. That will lead to decreased venous return to the left heart and increased venous return to the right heart. So if there is more blood in the right heart, so it will take more time to eject those blood. So the time to eject the blood which is present in the right ventricle, it is more than the blood present in the left ventricle, so it will obviously take more time to eject those blood. So P2 will be later in the aortic valve. A2 will come close, A2 will be earlier than P2 because there is less blood present in the left ventricle, so it will pump it in less time. So A2 comes before the P2 in case during inspiration. Okay, so right ventricular stroke volume increases due to this increased venous return, and so it takes longer time to close. So P2 is delayed in case of during inspiration. The left ventricular filling is decreased, so left ventricular stroke volume is decreased, so A2 closes earlier. So this is the physiological cause. Now what happens in case of ASD? So during ASD we have, I told you that during ASD there is volume overload in the right side of heart. In right atrium or right ventricle there is volume overload. So obviously the stroke volume of right ventricle is more than stroke volume of left ventricle because the blood from the left side is shunted to right side. So obviously if the blood from the left side shunted to right side, the stroke volume in case of left ventricle will be less and stroke volume in case of right ventricle will be more. So stroke volume of right ventricle is more than stroke volume of left ventricle, not during inspiration but every time during expiration also. The stroke volume of right ventricle is more than stroke volume of left ventricle, so it will take more time to close. So it will take more time to eject this blood into the pulmonary trunk via pulmonary valve. So P2 will close later, and A2 will close early because there is less blood than usual. Usually we have suppose 10 ml of blood in the left ventricle. Now 5 ml is shunted to right ventricle, so the stroke volume of left ventricle is decreased, so A2 will close earlier. So A2 will close earlier. What happens here? So this is S1. Now A2 will close earlier and P2 will close later. So in case of ASD this is what happens. Okay, so in case of ASD we have wide fixed splitting of S2. In case of ASD we have wide splitting of S2, and it is diagnostic. It is diagnostic of ASD. Okay, so in case of ASD we have wide fixed splitting of S2. Now we'll discuss about the ECG findings in case of ASD. We have primarily two varieties. One is ostium primum type of ASD, another is ostium secundum type of ASD. So we have ECG finding different in all these cases. In case of ostium secundum type of ASD we have right axis deviation, and in case of ostium primum type of ASD we have left axis deviation. So why this is right axis deviation and this is left axis deviation? So in case of ostium primum type of ASD it is left axis deviation due to left fascicular block and mitral valve insufficiency, that will lead to left ventricular hypertrophy. So I have discussed that in case of ostium primum type of ASD, it is defect in lower part of the atrial septum, interatrial septum. So lower part of interatrial septum is connected with the endocardial cushions, and endocardial cushion it forms the valves. So in case of ostium primum type of ASD, it is most commonly associated with valve defect. In case of, and most commonly it is mitral valve defect. So if the mitral valve is defective, and then left ventricle, in the left ventricle there will be volume overload. So in there will be chronic volume overload in case of left ventricle. So left ventricular volume overload, it will lead to LVH. So in case of LVH, obviously we have left axis deviation. And in case of ostium secundum type of ASD, there is, it is most common type of ASD, and there is more blood coming to right atrium, and from right atrium to right ventricle. So there is more volume overload in right ventricle, so it will be right axis deviation. So what is this left and right axis deviation? So in ECG, to determine the which axis deviation is there, we have to look for uh, two leads. First is lead 1, then we have lead AVF. We know that this is our lead 1, and lead AVF is perpendicular to lead 1, and lead 2 is 60 degree to lead 1, and this is 30 degree. Suppose I make a circle like this. If the QRS complex in lead 1 is positive, like this, if the QRS complex in lead 1 is positive, and the QRS complex in lead AVF is also positive. So if the QRS complex in lead 1 is positive, I will shade it like this, and if the QRS complex in the AVF is positive, I will also shade it like this. So this is coming the common area. This is called normal axis. It is called normal axis. It is 0 degree, it is 90 degree, and it is minus 30 degree. Actually minus 30 to plus 90 degree, this is called normal axis. And from minus 30 degree to minus 90 degree, this part, it is called left axis deviation. So where will we see left axis deviation? Left axis deviation is seen in case of left ventricular hypertrophy. In case of LVH, we will see left axis deviation. And this is called right axis. This is plus 90 to plus 180 degree. This is called right axis deviation. In case of right ventricular hypertrophy associated with right bundle branch block, we will see right axis deviation. So let us discuss more about this. So suppose this is lead 1, this is AVF. I discussed the normal case, if the QRS complex is positive in both lead 1 and AVF. Now what will be we see in case of ostium primum type of ASD. So I told you that ostium primum type of ASD is associated with mitral valve defects. So if there is defect in mitral valve, there will be volume overload in the left ventricle. So it will lead to left ventricular volume overload, and subsequently lead to left ventricular hypertrophy. So in case of LVH, we see LAD. So ostium primum type of ASD associated with left axis deviation. So what is left axis deviation? How will you know it in the ECG? So if the this part is called left axis deviation. Okay, this is minus 30 degree, this is 0 degree, this is plus 90 degree. Suppose the QRS complex from this side to come like this, the AVF, the QRS complex in lead AVF have to be negative, so that I can set this whole point. So in lead AVF, QRS complex will be negative. In case of lead 1, QRS complex has to be positive, so that I can set this whole area. And I told you this part making 60 degree with lead 1 is lead 2. So suppose then this is makes 90 degrees lead to, suppose lead to QRS complex is negative, then I can set this part. So this part is now fully shaded. So lead to QRS complex is also so lead to QRS complex is also negative. So you find an ECG in which there is negative QRS complex in lead AVF, negative QRS complex in lead 2, and positive QRS complex in lead 1. So this is left axis deviation. So here in which type of atrial septal defect we will see left axis deviation in ostium primum type of ASD. So in ostium secundum type of ASD, I told you, in case of ostium secundum type of ASD, it is most common ASD. It is volume overload in the right atrium, so there will be right ventricular hypertrophy. So it will lead to right axis deviation. In case of ostium secundum type of ASD, we will see right axis deviation. So this part is right axis deviation. So how we will come to this part? If the AVF QRS complex is positive and in lead 1 QRS complex is negative. In lead 1 the QRS complex is negative. So if you get a ECG in which the QRS complex is lead 1 is negative and QRS complex in lead AVF is positive, that will signify the right axis deviation. So in ostium secundum variety of ASD we will see right axis deviation, and ostium primum variety of ASD we will see left axis deviation. And auscultator finding in case of ASD is, what is this? That is fixed wide split of second hash-down, because the stroke volume in case of right ventricle is more than left ventricle, so it will take more time to close. So it will close earlier and P2 will close later. So these are the auscultatory finding and ECG findings in case of ASD. So what is the treatment in case of ASD? So what is the treatment in case of ASD? So treatment, what is the indication for treatment? We have elective surgical closure and early surgical closure. Early surgical closure in indication for early surgical closure is uncontrolled congestive cardiac failure. So uncontrolled congestive cardiac failure is an indication for early surgical closure of atrial septal defect. Here QP is to QS ratio is more than 2:1. And in case of elective surgical closure, and in this case there is no complications such as congestive cardiac failure, so indication is ASD and more than 3 to 5 years up to school going age, and there is most of the ASD goes spontaneously. So suppose this doesn't close spontaneously, no spontaneous closure for 3 to 5 years, and size is more than 8 mm. Size is more than 8 mm and it doesn't close up to 3 to 5 years, not close spontaneously within 3 to 5 years. Then we have elective surgical closure in case of ASD. And what is the early surgical closure? When we will suggest early surgical closure in case of QP is to QS ratio is more than 2:1 or is uncontrolled congestive cardiac failure. So